Hello everyone. Thank you for letting me present at Nephrology Grand Rounds today. For those of you who don't know me, my name is Ben Lidgard. I'm a clinician researcher here in the Division of Nephrology. Recently, I've been spending some time working at the lipid clinic at South Lake Union, and it's really made me think about how we prescribe statins to nephrology patients and whether we need to reevaluate our practices a little bit. I don't have any relevant disclosures. Our objectives for today are going to be to review the history of statins and where they act in the body. We'll talk about some of the guidelines in the general populations that govern their use. We'll talk about trials that have been done specifically in dialysis patients and patients with non-dialysis requiring CKD. And then we'll talk about the guidelines that have been derived from those trials, both those of KDIGO, our international guidance community, or the European guidelines as well. We'll talk about some practice patterns locally, nationally, and internationally. And when we wrap up, we'll talk about some conclusions and possibly some areas for future study. So cholesterol has had a long and storied history that I'll touch on briefly. The physician chemist Francois Pelletier isolated cholesterol from gallstones in the 1780s, although this molecule wasn't actually named cholesterine, which is Greek for solid bile, until about 1814 by Michel Chevreul. Its molecular formula was later elucidated by the Austrian botanist Friedrich Reimitzer, taking the cholesterol crown away from the French in 1888, about 100 years after it was discovered. This four-ring skeleton that we see in the upper right here really gave chemists fits in terms of discovering its actual structure until the 1920s. And this is work that Drs. Weiland and Windhaus each won a Nobel Prize for in 1927 and 28, respectively. And then in 1939, the Norwegian physician Carl Mueller described 17 families with elevated cholesterol levels and premature myocardial infarctions. And that really provided our first link between cholesterol and atherosclerotic cardiovascular disease. This condition was later termed familial hypercholesterolemia. Later in the 1960s, a team of biochemists identified the biosynthetic pathway for cholesterol, leading to the third Nobel Prize in the cholesterol cap in 1964. And the key step here was identified to be the action of HMG-CoA reductase. This led to a boom in compounds that could inhibit HMG-CoA reductase and decrease cholesterol levels, starting with compactin in the 1970s. This never reached FDA approval because of concern for tumor risk in dogs. However, a number of statins were later approved, starting with lovastatin in the 1980s, 1987, then pravastatin, simvastatin, et cetera, et cetera. So cholesterol is a complex molecule, as we showed very briefly, and its synthesis is equally complex. I'm just going to touch on it briefly. Acetyl-CoA up here in the upper left corner is converted to HMG-CoA by HMG-CoA synthase. This molecule is then broken down to CoA-SH, this huge chunk in blue here, and melavinate, which is the little orange molecule by HMG-CoA reductase. Then for interest, this little melavinate molecule is then lengthened on to squalene, and that has carbons and double bonds in all the right places to get it converted to linosterol, which is actually starting to look like cholesterol that we see in the bottom left there. So it's kind of interesting that we take this huge chunk of a molecule away, leave melavinate, and that gets lengthened out. But that's the rate limiting step of this whole process. And that is where statins act to inhibit this process. So we've talked about how statins inhibit cholesterol biosynthesis. So it stands to reason that statins should lower total cholesterol and LDL cholesterol. And that's exactly what was seen with lovastatin use. Leading up to its clinical trials, preclinical trials showed a decrease in total cholesterol and LDL cholesterol of about 32 and 39% respectively. And then several randomized controlled trials later confirmed these results. So these are data from the AFCAPS TexCAPS study, in which 6,500 outpatients in Texas were randomized to lovastatin versus placebo. And compared with placebo, lovastatin actually lowered your total cholesterol, LDL cholesterol, and triglycerides, and led to an increase in HDL cholesterol levels as well. Furthermore, and perhaps more impressively, lovastatin actually prevented all analyzed cardiovascular outcomes in the study. And the hits just kept coming for statins. It wasn't just AF caps, TEX caps. This is a review of what everyone here already knows. So between 1993 and 2003, there were 10 randomized control trials of statins. And then they were meta-analyzed, although one trial was excluded for heterogeneity. And these trials all agreed that statin therapy decreased the risk of major coronary events, cardiovascular deaths, and strokes, with the number needed to treat of around 4. So ACC-AHA later released these guidelines in 2018 and 2019 after a lot of these trials and meta-analyses were released. And most lipidologists that I've talked to consider these to be the definitive general population guidelines. These guidelines really rely pretty heavily on LDL cholesterol levels in order to determine which patients get a statin. So basically, we see here that everyone with LDL cholesterol of greater than 190, which is very, very high, they all get statins at a high intensity. All diabetics with an age of at least 40 years also get a statin. It's just up to your risk enhancers, which include chronic kidney disease conditions, to determine whether you get a moderate intensity or a high intensity statin. And then here also, basically everyone with younger age doesn't have diabetes. The ACC-AHA does rely pretty heavily on risk stratification. So they recommend the use of risk scores such as the pooled cohort equation to determine what someone's 10-year cardiovascular disease risk is. Just looking at these kind of guidelines here, if we're considering chronic kidney disease to be a risk enhancer, which ACC-AHA does, then ACC-AHA would probably recommend statins for the majority of our patients, either by ilk of their being slightly older, having diabetes or other comorbidities, or just having chronic kidney disease with a slightly elevated cardiovascular disease risk. However, and this is a big caveat with general population data, these were derived from general populations and for general populations. Chronic kidney disease has got different physiology. It's not always clear that we can generalize population data to chronic kidney disease. Dialysis is even more intense. Everything's dialed up to 11, as I like to say. So what do we do in dialysis patients? And what about patients that have received a kidney transplant? These are different populations. It's not clear that general populations data are going to be generalizable. So we only need dedicated studies. And the first study that I could find that attempted to address this question of chronic kidney disease was actually a subgroup analysis of the MRC-BHF heart protection study. Now, this was a trial of simvastatin for primary prevention in patients with and without diabetes in the UK. This was published in 2003, and the authors here stratified their analyses by elevated creatinine, which they defined as a creatinine of greater than 1.24 for women or 1.47 mg per deciliter for men. And although the authors further stratified here by diabetes status, you do see that there's a signal that statins should reduce risk for cardiovascular disease in patients with elevated creatinine or presumed chronic kidney disease as well. The number needed to treat here looks pretty good. So in the same year that that trial was published, in 2003, the SHARP trial also started enrolling. And this was a very large randomized control trial, which was designed to evaluate simvastatin plus ezetimibe versus placebo in patients with chronic kidney disease. And this actually included patients with dialysis requiring kidney failure, as we'll touch on in the next few slides. These patients did not have known cardiovascular disease, so it's primarily a trial of primary prevention. And they ended up enrolling just over 9,200 patients. And they found that the intervention actually decreased the risk of the composite of non-fatal myocardial infarction, coronary heart disease death, revascularization, and non-hemorrhagic stroke, with a rate reduction of about 17% here. I'd just like to touch on briefly that statins were very well tolerated in the SHARP trial. If we look at the rates of myalgia and creatinine kinase elevation between the two arms, we see that they're almost exactly the same. No statistically significant differences in tolerability events. As we discussed, SHARP also included patients that were on dialysis at the time of enrollment, and about a third of patients in the study were on dialysis. The investigators would evaluate for effect modification by dialysis status, and as we see here, there's a bit of a trend towards improvement and risk reduction in the dialysis arm, but this is not statistically significant as this crosses over 1. So it does look like there's a little bit of modification here. CKD shows clear benefit, dialysis maybe not so much. In the late 90s, the 4D or Deutsche Diabetes Dialyse study, sorry if I butchered the pronunciation, Dr. Pitchler, enrolled 1,255 patients with a mean age of 65.7 years. All these patients had diabetes and they were all on dialysis with the mean vintage of around 8.3 months. Participants were randomized to either 20 milligrams of atorvastatin daily, which is, again, a moderate intensity regimen, similar to what the studies in SHARP, or placebo. And atorvastatin resulted in about 42% lower low-density lipoprotein cholesterol levels. Pretty good, and on the same order of magnitude as the general population studies. However, as shown here, they did not show a significant reduction in the risk of composite outcomes in the atorvastatin versus placebo. The other big statin trial in dialysis was the Aurora trial. And now this randomized 2,773 patients that were on dialysis to rosuvastatin 10 milligrams daily. That's Crestor, but still moderate intensity dose versus placebo. And as shown here, the authors did see a good improvement in LDL cholesterol and total cholesterol and triglyceride levels. They also saw a modest improvement in HDL cholesterol levels. These are, again, in line with general population study findings. Unfortunately, in line with other dialysis studies, rosuvastatin did not decrease the incidence of the composite endpoint, non-fatal stroke, myocardial infarction, and cardiovascular death. A few more trials were later published. For sake of consistency and just time considerations here, we'll skip to the meta-analysis. So in 2012, a meta-analysis of available dedicated CKD trials and subgroup analyses was conducted. And the results showed that statins reduced the risk of all-cause mortality, cardiovascular mortality, major cardiovascular events, and fatal and non-fatal MI in patients with chronic kidney disease. It is worth noting here that dialysis-dependent kidney failure might modify the association with reduced risk. So if we just look at the second line here, this major cardiovascular events, we see that patients without dialysis requiring kidney failure, which is CKD, have a pretty strong risk reduction here, number needed to treat of about 4. But patients that are on dialysis or patients that have received a kidney transplant do not have the same risk reduction. And the p-value for effect modification here is quite minuscule, suggesting that dialysis is a pretty significant finding. So briefly, transplant has been less well studied. About as far as I can find, there's been about 1 large randomized trial. I just might not have been looking hard enough. But this was the ALERT study in which patients with kidney transplant were randomized to fluvastatin, either 40 or 80 milligrams. Either way, it's a moderate intensity regimen, or placebo therapy. And this actually showed that patients with kidney transplant had a 35% risk reduction for the composite of cardiac death and definite non-fatal MI with fluvastatin therapy. So we've talked about the trials. Let's just sum up what we found with all these trials. It seems to suggest that statins prevent cardiovascular disease in patients with normal kidney function. They seem to improve outcomes in patients with non-dialysis requiring CKD and in patients with kidney transplant, but not in patients with kidney failure on dialysis. So in light of all these findings, KDIGO published a clinical practice guideline in 2014 and specifically addressed the question of lipid management in patients with CKD. These were largely influenced by SHARP, being the largest statin trial in CKD. And first, they recommend checking a lipid panel in all patients with new CKD. And this is less so we actually have something to follow, and more so that we can refer out to a lipid clinic or a lipid specialist if the numbers are really, really bad. So for cholesterol, LDL cholesterol of greater than 190 or triglycerides over 1,000, they do recommend referring to subspecialty. Next, patients older than 50 years old with CKD 3A or worse, or an eGFR less than 60 that are not on dialysis are recommended to get a statin therapy. This is in line with SHARP trial and the meta-analyses. Patients aged at least 50 years with proteinuria CKD and eGFR greater than 60 are recommended to get a statin as well. And then you can consider statin for younger patients if they have known cardiovascular disease or stroke, diabetes, or an elevated 10-year ASCVD risk of 10% or more. Now, this is using the general population studies, the pooled cohort equation, or the Framingham risk score. Finally, if you're on dialysis, they recommend not initiating a statin, but in the kind of guideline recommendation realm of waving their hands around saying we don't know, they say that if you're already on a statin before you start dialysis, you might as well continue it once you get to dialysis. This is just reflecting that we've not seen any improvement in 4D dialysis subgroup analysis and SHARP or any of the other dedicated dialysis trials. There's really no improvement for statin therapy. And then finally, in line with the ALERT trial findings, KDIGO does recommend that all patients that have received a kidney transplant also receive a statin for primary or secondary prevention of cardiovascular disease. Just to point out a couple of limitations here, they don't really recommend following lipid levels. We don't know what patients' lipids are going to do in response to this, and they say that it's not really that important. You literally just check the lipid panel, and then regardless of what it shows, put them on a moderate dose statin, set it and forget it. Second, KDIGO is relying pretty heavily on these risk scores, these 10-year ASCVD risk scores, to determine whether statins should be given in younger CKD patients. And as we'll get to next, I'm not sure that this is 100% the most appropriate move all the time. And the reason that I say that is from some work done by Viner et al. In 2007. So these authors looked at the Framingham risk score, which was being used to evaluate 10-year CVD risk in patients with chronic kidney disease. And this is specifically CKD G3A to 4 in the atherosclerotic risk and communities study. And they found that this risk score consistently underestimated cardiovascular disease risk, only catching CVD risk about half as much of the time as it should. They were able to recalibrate the equation to improve its predictive power in women, but it did not statistically significantly improve in men. And this is in line with our prior findings as well. So in 2022, we published findings from the Crick cohort, showing that the pooled cohort equation, which is the more modern risk score that ACC/AHA recommends most of the time now, has only moderate discrimination in patients with CKD, and it underestimates cardiovascular risk in these patients overall. That's noted here by not only the slope being greater than 1 of this line, it's north of the line of identity, but also these risk boxes at the higher deciles of risk being north of the line of identity as well. So these findings would seem to suggest that while the pooled cohort equation underestimates CKD risk, it doesn't really say much about the eGFR. I didn't include this table just for brevity, but this difference was most pronounced in patients with more advanced CKD. So once your eGFR got less than 45, the pooled cohort equation only caught about 50% of the actual risks that we saw in the cohort. So, knowing that cardiovascular disease risk scores might actually underestimate your risk for patients with chronic kidney disease, I'd like to propose that we may fall short of treating some patients that could derive benefit from statin therapy if we go by the KDIGO guidelines alone. It's possible that we may need to give statins to more CKD patients than KDIGO recommends. I'd like to compare briefly how the KDIGO guidelines differ from those of the 2019 European Society for Cardiology and European Atherosclerosis guidelines. So the ESC-EAS actually considers that all patients with KDIGO stage 3 to 5 CKD that are not on dialysis are considered to be at least high, if not very high risk of ASCVD. And that, I think, is what Viner et al. And our paper in Crick would agree with. It seems like CKD just bumps up your ASCVD risk score, and the risk scores might not be the most reliable in this population. And they recommend that all these patients, regardless of age, get a statin. For what it's worth, their recommendations mirror the guidelines of KDIGO in terms of kidney transplants. They recommend that everyone gets a statin. And for dialysis patients, they say if you're on one when you start dialysis, you might as well continue, but don't start at statin de novo dialysis patients, no benefit. Okay, It's a lot of ground, a lot of trials. We've talked about what statins do, how they do it, the guidelines for their use in general populations and nephrology patients specifically. And I've made the argument that we might not be treating enough patients with the current guidelines. But this really brings up the question of, are we even following the guidelines? Are we prescribing statins to all the patients that KDIGO says ought to get a statin? So the Seattle Kidney Study enrolled patients from the VA, Harborview, and UW starting in 2004. And I thought it might be interesting to kind of look at how patients in our region have been prescribed statins. So I went back through the data, and going by the ACC-AHA criteria, it seemed like about 2/3 of patients in the study had an indication for statin therapy, but only 238 of those 400, or about 60%, were actually prescribed a statin. KDIGO guidelines would suggest that 453, or 3/4 of patients, had an indication for statin therapy in the Seattle Kidney Study, but only about 270 patients out of those qualifying 453, or about 59%, were actually prescribed a statin. These are data from the most recent USRDS data report. Now, this only captures Medicare Part D recipients, but it can still be kind of a useful benchmark to check against. So we see that about 55 to 56% of patients on dialysis, hemo or peritoneal, are on statins. This is a little bit lower than I might have expected, knowing that most CKD patients will have an indication for statin at some point. But considering that a lot of patients might crash into dialysis, I suppose it's not the most surprising. Slightly more surprising to me was that only about 61% of kidney transplant recipients were on statins, when the ALERT trial and KDIGO and European guidelines all suggest that 100% of these patients ought to be on statin. These are some interesting data from a more international setting. So the authors of this study, which was published last year, actually evaluated international prescribing practices for lipid management in CKD patients. And this was leveraging data from the Kidney Disease Outcomes and Practice Patterns Study, or CKD ALPS. This is a multinational study of patients in outpatient CKD clinics, and everyone here had an eGFR of 60 or less. So just as a reminder, KDIGO recommends statins for everyone with eGFR less than 60 and age of at least 50 years, with consideration for younger patients. And we see here that this is a primarily older population, but statins are prescribed much less often than we see that they might be. Just looking here in Germany, 94 to 95% of patients met the criteria for KDIGO, but only 55 to 49% of patients were actually prescribed a statin. And it seems clear that the prescriptions may have been driven by cardiovascular disease burden. This isn't all primary prevention anymore. This is secondary and primary prevention. But for those with no known cardiovascular disease, or the not burden, as the authors describe it here, we should see slightly higher use in the age 50 or more group, instead of the 37 to 48% use that we see here. So all of a sudden, that 59% of qualifying patients in SKS that got a statin doesn't seem too bad. It seems pretty good, at least looking at France and Germany. I think that the numbers for France and Germany are a little bit low, especially considering the European guidelines, where statin use is recommended in every single one of these patients, because they all have CKD 3A to 5 on dialysis. So in conclusion, I'd like to just state once more time that chronic kidney disease is associated with a very high cardiovascular disease risk, and statins have been shown repeatedly to improve these outcomes with fairly low numbers needed to treat and tolerable side effect profiles. They seem safe and effective in these populations. Both KDIGO and the European guidelines differ slightly, specifically in regards to risk stratification, but they both seem to recommend that we might be underreaching the mark in terms of how often we should be prescribing statins. We might be missing some patients that could derive benefit. So I think that further descriptive work looking at practice patterns, why these patients aren't getting statins, or possibly implementation studies to see if we can improve prescription practices might be useful in terms of preventing cardiovascular disease in this uniquely vulnerable population. In closing out my final grand rounds as a clinician researcher, I'd like to thank my primary mentor, Dr. Bonsall, as well as my mentoring team, Dr. Zelnick, Savitha Subramanian from the Division of Endocrinology, Andy Hoofnagle, and Rosanna Lamater from the Division of Medicine. I'd like to thank my co-fellows and co-AIs over the years for their support. I'd like to thank each and every one of you in the division and at the KRI for your support, guidance, and mentorship over the years, but we frankly don't have time for me to call out your names one by one. And I'd like to thank the ASN for my current grant support and the UW-ITHS for my upcoming grant support. Finally, thank you all for attending today and listening to me rattle on about statins for another 30 minutes. If you have any questions, I'll be happy to take them this time.
Thank you, Ben. Great. Really comprehensive review of a important topic, and clearly little room for those early career investigators that are interested in doing more. Questions for Ben? Well, oh, go ahead, Leah. See you on mute.
Well, actually, there's a question in the chat from Stuart.
Oh, thank you.
Yes, Stuart asks, I understand statin usage you recommend for CVD risk. What about their possible benefit for pleiotropic benefits on CKD, such as reduced cell death? That's a really good question, Stuart. And unfortunately, I really didn't read into those possible benefits much. But I agree with you that statins have potentially a lot of benefits outside of just preventing cardiovascular disease. And I wonder if we might not need to think about in terms of like large society guidelines to a slightly greater degree. So I'm sorry, I don't know specifically, but I agree with you.
Thanks, Ben.
Ben, it's Leo. What I think that the cardiologists at Harborview, if you have a dialysis patient that comes in with a STEMI and gets a PCI urgently, they will uniformly want the patient on a statin. What is your reaction to that? Patient on dialysis.
Yeah, and I am a little bit torn on this topic. I realize that there's a bit of equipoise in the trials, but I would like to point out that SHARP was always, it was just a primary prevention study. It's not a secondary prevention. So if a patient has clinically known coronary artery disease, I'm not sure that SHARP would be able to tell us one way or another, like we should or should not give statins in those patients. To me, at least, it seems reasonable if a patient has known coronary artery disease, even if they are on dialysis, they may derive benefit from statin therapy in terms of preventing further cardiovascular events. But I'm not aware of like good literature to support its use one way or the other in those patients. Secondary is a little bit different than primary.
Thanks so much.
Quick question from Bilal. Any thoughts on atorvastatin versus rosuvastatin?
Yeah, good question. That's a really good question. A lot of the societies kind of see these moderate intensity statin therapies as equivalent. There's not been a whole lot of literature, to my knowledge, that evaluates like moderate versus high intensity statin therapy for primary prevention. And all of the CKD trials, as I tried to point out, really did focus in on moderate intensity statin. I think this was mostly in an effort to lessen the side effect profile, but I'm not sure. So rosuvastatin can be given at a moderate intensity dose. 5 to 10 milligrams of rosuvastatin is, I believe, still a moderate intensity statin. A lot of the lipid experts at South Lake Union clinics have even included really like rosuvastatin in these patient populations. So I might tend toward that. But if you can't get it covered, atorvastatin should be equivalent from the, at least from the trial data.
Well, some more clinical questions trickling in for you, Ben, needing your expertise and understanding of physiology to interpret some ambiguity in the recommendations. So maybe take a look at the chat there, but let's move on.